Okay, so hi everyone, and welcome to this live session with Meta. I'm very happy to today to actually have a very distinguished guest with me. He's actually one of my friends. He's been my teacher. I was privileged to actually learn PGT with him back in London, and that was a very great time that I had with you, Alpesh, at UCL. He is the director of IVF London, which is a very new company for him, and it's actually gaining a lot of positive reviews in UK as well as with HIFA. Alpesh, I'm sure you're going to talk a little bit about IVF London and your results and how you've actually really breaking through the scenes. But today's topic is basically on COVID. And today we are going to actually discuss strategies on how to restart IVF laboratories. We know that HFEA has actually now come up with a notification that IVF units can start reapplying to HFEA to begin practices from the 11th of May. So we're going to talk a little bit about that and basically general precautions that embryologists have to take when they restart their laboratories, how to look after the equipment, etc. So all this is going to be discussed today. So over to you, Alpesh. Just give us a quick introduction of you as well as your company, and then we begin this session.
Thank you so much, Keshav. Absolutely a pleasure to participate in this webinar. My name is Alpesh Doshi. I'm a clinical embryologist by training and profession. And just in 2018, I started my own clinic here in London. And the clinic is called IVF London. And it is one of the few or very first clinics that is embryology led. Usually IVF clinics are very clinician led, but we started this brand whereby we wanted the science and technology to be at the heart of the operations of a fertility clinic, because that's where a lot of the developments are going. And in the last 10 years, we have seen a lot of developments that are focused around the IVF laboratory. So that was the whole, phenomenon around starting a clinic whereby the focus is purely or mainly on the lab. Now, I'm absolutely happy to participate in today's topic. And by no means am I an expert in this direction or the virology of it. I'm not a virologist, but certainly I've had quite a bit of experience at looking at how to open up an IVF clinic. And as you all know, in the UK, we are now starting to get ready towards opening IVF clinics. You may have heard that our regulatory authority, which is the HFEA, have started to, or will start to invite applications from individual clinics to reopen. Now, this is not going to be a straightforward process. Just for those of you who may have heard that from the 11th IVF is opening in the UK, that's not going to be the case. It's really going to be a very systematic approach. It's going to be a very staged approach. So the first thing is that there is going to be a self-assessment questionnaire that we as clinic leads will have to fill out, which will enable us to prepare with everything that we need to have in terms of SOPs, in terms of patient information leaflets, in terms of the testing strategies, etc., etc. So this is going to be a slow process. IVF is not going to resume on the 11th in the UK. The process of applications will start, and then I think by about the last week in May, we may be able to start cases.
Yeah, so I think that this is the biggest misconception that most of us have at the moment, where any notification that comes from ESHRE or any notification that comes from HFEA, we take it in the very literal sense, and we don't really see what kind of intricacies are involved in your practices as well as in these guidelines that both these societies actually set up. And this is one of the reasons why I really wanted to talk about this topic, because even when ESHRE came out with the guidelines of how to restart the IVF units, we all jumped in India. We all jumped back, and we were actually discussing quite a bit in most of the WhatsApp groups that we have on restarting IVF as soon as possible. But we have to understand that Europe has already gone through this pandemic, and in India, it's still somewhere in the middle stages as of now. So those guidelines might be applicable to us, but they might be applicable probably a month later or 2 months later or 2 months down the line. So that's something that I really wanted to talk about today. And you were talking about this self questionnaire and maybe a triad system that's there. Can you touch upon how you're developing these SOPs to actually segregate your patients? Let's talk about patients first, and then we start talking about the staff.
So I think, in a way, I'm in a good position to kind of look at things holistically as an IVF clinic, because I run a clinic and not just a lab. So I think I'll talk briefly on how to start up a clinic first, and the various aspects of the clinic that really need to be kind of looked into when we start, opening up various aspects of various departments. So there's to be a lot of thought that goes through, and we'll talk more about the lab in a bit. But things like, how are we going to take payments? How are we going to keep social distancing whilst patients are in the clinic? Typical examples are contactless payments, just backs payments, whereby there's no direct contact, no cash to be handled, screen at the reception to make sure that there is distance. All seating for your patients has to be kind of 2 meters apart. You need to also think about how you're going to space your appointments. So typically,
Yes.
just to give you an example, all our scans, although scans only take 10 minutes, but we are keeping 30-minute gaps between each scan, just to kind of keep the social distancing measures. For egg collections as well, we're going to keep 90-minute slots. We all know that
Okay.
egg collection can take only 15 minutes to half an hour.
Yeah.
But again, we've got 90-minute slots just to kind of minimize that kind of overlap between patients. So that's the first thing that I think we need to look at, in terms of the admin side of things.
Yeah.
Then, one can then start moving into the more intricate side of things, and we'll discuss PPE. But now let's move on to the lab. Now, the lab has several aspects that I think we need to carefully address one by one. Now, first is obviously sanitation and decontamination. Now, it's very important for all of us who are going back into the lab and starting the lab up again to effectively use a disinfectant which is active against COVID. Now, I've heard a lot about in several webinars about using sodium hypochlorite. Now, I want to.
We were just talking about sodium hypochlorite like 5 minutes before this webinar started in one of the embryology groups. Please touch upon that as well.
So, in my opinion, sodium hypochlorite is not safe to use in the lab.
Okay.
Because chlorine hypochlorite turns into chlorine ions, and you will smell very active chlorine in the lab. Now,
Okay.
as embryologists, Keshav, anything that smells quite heavy, you don't
problematic.
So I would recommend using sodium hypochlorite in the lab. Having said that, what other agents do we have that are active against this virus? So USAFE is a product we use in the UK. I don't know if it's available in India.
It's available in India, yes.
Brilliant. So USAFE, we've checked with it, and it's active against coronavirus. So again, that is quite a good product to use in the laboratory. So effective disinfection and sterilization is very important. People often forget about the air handling unit. We all know the IVF lab has to be under constant positive pressure.
Yeah.
And obviously the filtration system. We know that this virus is airborne as well, and it can be trapped in your filters. So the first thing to do is to change all the filters in the air handling unit before embryologists go back. So that is very, very important, because otherwise you can have a bioburden of virus, that is still active in these kind of air handling units. Now, then revalidation. Of course, because when you shut down any equipment, and most of the labs must have shut everything down because they didn't know how long they're going to be closed for. So the revalidation is extremely crucial of all the equipment. And of course, if you do shut down over a Christmas period, you know what the revalidation protocol is. And every lab has got its own revalidation protocols. So I would urge embryologists to make sure that they actually revalidate their equipment as they would normally do in a Christmas closure, for example. Now, revalidation is one thing, sterilization, decontamination. one thing that we tend to have here in the UK is they call a hydrogen peroxide bomb. I don't know if that's available in India. So we have companies that can come at night. They just release a hydrogen peroxide bomb in the lab. Of course, no one's there, but everything gets decontaminated. So again, that is something that we're going to be using here in London before we start our first case. At night, they're just going to come and set up the bomb and then it'll go off. And the good thing is it breaks down into water and oxygen. So it's
Okay.
there's no residues of any kind.
I'll go back to a very basic question, Alpesh. How long do you feel like, how much time before should one start really, one should actually start doing all of these activities before starting a laboratory? So, like, basically, it's advised about 2 weeks or something. Should it be more than that
No, I
or
think two
less
weeks
than
is plenty. I think the moment you see your first patient in clinic, or when you start your stimulation, that would be the day that the lab starts doing everything. Don't forget, even when you're disinfecting, you want to make sure that all the VOCs and everything are released out of the
that?
system. 2 weeks is
Because once the lab is shut for so long, especially when in India, a lot of people are doing batch IVF or doing like accumulating cases and doing them like on a particular day, etc. So the labs usually are shut. So in those cases, VOCs do get accumulated, and that's why we have to give the lab a little bit of time to actually get back to the best of its health, and then only start doing cases. So that's, I think, one very important point that all of us have to consider. So we're getting some questions on filters. So
Mhm.
Sarabpreet is here asking a question, and or he's actually making a comment. Should we change filters only if there is an evidence of the virus in the patient, or should we just do it for before starting the laboratory as such?
So you see, Keshav, we can we you see pre the lockdown. Do you agree that we were all in a phase whereby we don't know whether we had affected patients or not? Now we're talking about all these safe practices when it comes to cryopreservation, etc. But I'm pretty sure that there's a mass number of people who are asymptomatic but are positive for corona. Now,
That's true.
these patients could have already gone through your system, and hence I feel as a clean slate. How in Christmas we change all the filters anyway. I
Yeah.
think we need to treat this as a Christmas closure, rather than risk assessing who we had pre-closure and who do we have post-closure. I
Yeah.
appreciate there's a cost impact in all of these things, but let's treat this as a Christmas closure so that at Christmas we don't have to do everything again.
Yeah, and that's the next question that follows. So once we change these filters now, how often do we have to do it? Because now this is a period where we might still be getting asymptomatic patients into our clinics, even once we begin the practice. Now, there is a system of triage that we are going to talk about, I think, going down this webinar. So maybe that might be a way of actually restricting patients. But general practices, do we change them similarly and we are changing them in 3 months, or should it be more frequent in the current scenario?
See, at the moment, everything that we come up with in terms of a number is very arbitrary, Keshav, because we
Yeah.
don't know whether it's 1 week, 1 month, 3 months, 6 months, or 1 year. So I think that there is an element of good practice without evidence, and there is an element of knowing that everything that we're going to do now is just so much more streamlined than what we used to do before the lockdown. So one thing
Yeah.
we all know that we know so much more now, which has shaped our practices going forward. And before we closed down, we were doing things very obliviously.
Yeah.
So I think, um, I don't know is the answer, whether I should say every 1 month or every 3 months. But considering that we have a very streamlined approach now of how to take patients through, it is very important to also understand that we have really minimized the risk of everything that potentially goes through. Of course, the risk is not zero, the risk is
Yeah.
still there. But as long as you have ensured that your processes are in line with the national consensus guidelines, um, You see, one thing I want to add here, Keshav, that I appreciate that ESHRE has come up with its guidelines and triage questionnaire, ASRM have. We're waiting for the British Fertility Society guidelines to come out. We're also waiting for the ARCS guidelines to come out. Now, in a way, I think we're privileged and honored to have these guidelines to kind of guide us through. And I would really encourage that embryologists and lab managers in India do use these guidelines in a very positive note and
Yeah.
incorporate them into their systems. I certainly think that that's a very, very important thing to do, because we all know you guys have, embryologists in India work in very, very busy centers. So the throughput or the volume of patients is going to be like a floodgate as it opens.
That's true. But Alpesh, how would all of these guidelines work for India? Now, I'm sure that there are a lot of processes that all of you look after. Your SOPs, your policies, etc., are actually to the point. But when we talk about a scenario as India, which India is in at the moment, where IVF is offered at a relatively cheaper price as compared to what's there in Western countries. Do you see that we would also be able to incorporate all of these changes looking at the cost, or the cost would inflate quite a bit in the current scenarios? I really can't predict how patients are also going to take this change. So I'm not really sure. I'm actually quite skeptical of how the IVF industry is going to evolve in our country. But I do feel that now is the best time to actually standardize practices, because we've now been hit with something so hard that we now actually have to rechannelize our brains. We have to consider that these are precautions and these are quality measures that all laboratories in India have to take.
You
Coming
brought up,
back,
yeah, sorry.
I'm sorry, I'm just going to come to a question which Gaurav was asking at the moment, which
Mhm.
was according to the in regards to the same topic that we were discussing. Now, there are a lot of laboratories in the country which don't have air handling units. Uh, what do you think of those? Uh, how do they restart? And is positive pressure something which now becomes necessary in IVF laboratories all across even the developing countries?
So in the UK, certainly there's a regulation that if you do not have positive pressure in your lab, you can't be licensed to do IVF.
Yeah.
So from my perspective, that is quite important to have positive pressure. And in the current scenario where we're dealing with kind of pathogens and viruses, it makes it that much more important for labs to have positive air pressure to protect, everything that we're doing
Yeah.
essentially in the lab, and to keep contamination even in the form of their infection control policy. So that is very important. Now, for labs that do not have positive pressure, I think their aseptic techniques, for whatever filtration they have in the lab, whether it's Coda towers, etc., if that's what they have, then they need to make sure that they are changing those filters. But if they don't have positive pressure, then in my opinion, it makes them a bit more vulnerable in the whole equation. I
What
certainly,
about UV?
yeah, sorry.
What about UV or ultraviolet decontamination?
Yeah. So many flow cabinets that we use do have a built-in UV lamp.
Yeah.
So, for example, in our SOP that we have created for opening up now, every night we have programmed the UV light to go on for about half an hour. Of course, you've got to do it when there's no eggs and embryos outside. But we definitely would put the UV on for 30 minutes at night at midnight, and all our handles, all the tool holders, and everything are going to be there overnight, so it gets decontaminated.
Yeah. And
The
and we
other
were,
thing
yeah, tell me.
mentioned was, yeah, you mentioned a very good point about having all these policies, which essentially may work in the West, but when it comes to cost, India is much cheaper, and hence, how is everything practically applicable in this scenario? So you see, Keshav, you're absolutely right that a lot of these, to implement a lot of these things that essentially ESHRE or HFEA have come up with, is a very expensive exercise. Even for clinics like us, this adds a huge layer of additional cost.
Yeah.
I still feel that unfortunately, we're in an era where we have to take certain levels of precaution. So one area where I feel we shouldn't really compromise is personal protective equipment, both for staff and for patients. And of course, it can be argued that do patients also have to wear PPE? But that is certainly in our SOP that patients will have to be putting on PPE as well. The other layer of cost is testing. Now, I don't know how
Yes.
much these tests are costing in India, but in the UK at the moment, a test is costing around £75. So
Okay.
that is again something we will have to absorb for our own staff when we test them, because that is also part of our SOP that as we all decide to go back, all of our staff have to be regularly tested. Whereas for patients, I can understand that you may want to pass on this cost to the patient, um, but there are definitely some measures we will have to incorporate without thinking too much about the cost, which I appreciate is a concern. But these next 3 to 6 months are going to be quite difficult when it comes to absorbing these extra costs.
I agree with you. So I was actually talking to Marcus. I mentioned this to you before we began the webinar. And Marcus Messinger of Spain, we actually had a session with him a few days ago on a similar topic. And their strategy at the moment is that if their staff is not showing any symptoms, they are not really, actually, Spain has not really advocated any test for such people. Even if you have milder symptoms, what they're doing is that they're doing the antibody testing and not the main diagnostic test. And only when you have like major symptoms is when the test is actually advocated. So that's how they are like going about it. We also don't know about the efficacy of these tests, the
Yeah.
sensitivity of these tests. One test can be positive, the other can be negative. It's quite a chaotic situation that we are in at the moment. So what would be your views on staffing? Should we follow like a triage system for them? Should we follow a questionnaire for them, or should we like mandatorily test all of them? And second thing, should we get all the staff back in, or like phase it, or do it alternate days, or do it alternate weeks? How are you planning? How many embryologists do you have like currently?
Just two, me and a
Just
junior.
oh, you're
So
lucky.
two of us. So we're very small. But that's a very good question, because essentially these guidelines are made for over or also busier clinics where there is 16
That's
embryologists. So I'll go back to the testing part. So what we're doing in our clinic or in a lot of the clinics, and I'm quite fortunate to be on a WhatsApp group of 84 lab managers in the UK. So a lot of this gets discussed on that platform. So yes, all staff are going to be first filling out a questionnaire, a triage questionnaire, which is going to be reviewed by the occupational health. But at the same time, we are going to start off by doing a antibody test on all the staff. If they
okay.
are antibody positive, and don't forget, we only have IgG at the moment. IgM
That's
can be discussed. What else do we have which is good enough? You are absolutely right. The tests, we don't know, the efficacy of these tests. We have to live with what we have. But we would start off by doing an IgG test on everyone. Anyone who is IgG positive, we know that they have got antibodies for it. So then essentially they don't need to be retested again. If staff are IgG negative, then they would have the PCR test to see if they carry an active infection. If their PCR test is negative, then they have to be triaged regularly till the point that they develop symptoms, if they do.
yeah.
And if they develop symptoms, then you retest them. So that is staff. For patients, we are thinking about testing all of our patients who are essentially going to be starting stimulation. The important question with patients is at what time is the ideal time to test them? And again, we've seen a lot of variation in answers to what other IVF clinics in the UK are doing. Some are starting before stimulation or on the day of stimulation. Some are testing on day 10 of stimulation. Some are testing as late as day of egg collection. So again,
Yeah.
there seems to be a bit of discrepancy and non-cohesion in terms of when is the right time to test.
It's such a problematic area because the patient can get positive anytime during stimulation or
Yeah.
like till the time of embryo transfer. And even if you test, like if you're testing before, if you're testing when you're starting stim, the patient can get pregnant later on. And Gaurav actually here is saying that you can't really test these patients. The government of India is not really allowed testing for asymptomatic patients. But once you restart, Gaurav, we're talking about once we come back into IVF practice, do we feel that testing will be important? Is it a necessary step that we have to take in order to safeguard the other patients that are coming in order to safeguard our staff, or should PPE just be enough to manage these cases?
So I think obviously I'm going by what the current guidelines are in the UK.
Yeah,
And although ESHRE has not suggested that every patient gets tested, ESHRE has only suggested patients who are symptomatic or who are showing
showing.
non-related symptoms get tested. So patients who are showing no symptoms should not get tested. But I think as
Yeah.
a good practice guideline, what most of the UK clinics are doing is they are testing all the patients that are going through to egg collection.
And Alpesh, what happens once these patients are tested and they come out as positive? Now, Dr. Sapna's also asked the same question, and Niharika's also asking the same question. So, if they come out positive mid stimulation, should we continue the stim and freeze, or should we cancel? Or so, what are your SOPs for this?
So again, we're very clear on that because we need to have clear guidelines even for a patient consent. And let's not forget that also patients will need to sign a consent to to make sure that they are aware of what's going to happen if they become
Yeah.
positive in the journey. So most of the UK clinics are taking the approach that if someone turns out to be positive in the journey up to stimulation, then they get cancelled.
Okay. Wow.
They get cancelled. And patients will sign up for that. They know that they'll get cancelled. However, um, if patients are going to show positive between egg collection or after egg collection, then we will have to freeze their embryos in a closed system, not an open system. And we'll talk more about the lab side of things, of course, going forward. But the answer to your question is if someone turns positive before egg collection, they will be cancelled. Now, the two exceptions to the rules are patients who have cancer or are oncology patients and patients at risk of OHSS. These two
Okay.
categories of patients we have been allowed to proceed with egg collection, even if they are COVID positive.
Oh, that's a very good point. And I'm sure that you're getting quite a lot of cases for fertility preservation in the UK. What about the poor responders and the older age group patients where they've already lost 3 months of time, maybe even more for cities like London and cities like Italy and China. Um, do we cancel those patients as well, or do we freeze such cycles? It's such a dilemma for all of us. I can't really. Uh,
Unfortunately, Keshav, there will be so many permutations to this because
yeah,
every patient will have their own reason to why their treatment has to go on.
yeah,
So I think one has to just play by the rules. And I think we're quite fortunate that in the UK we have very clear rules around these things. Our regulatory authority says yes or no. And
yeah.
of course, to a certain degree, we as clinics are supposed to make sure that we risk assess. But I think the generic consensus is that if anyone turns positive before egg collection, they get cancelled.
Okay. So you were talking a little bit about consents, and you're saying that you're taking consents for cycle cancellation if the test comes out to be positive. Anything more specific that you've added up in your consents apart from this, like the risk of transmission, the someone being asymptomatic, and all of those issues? Have you done that for your unit?
So you see, the thing is that whilst patients are in the clinic, there is a certain level of risk that they encounter because they could essentially be in contact with an asymptomatic staff member.
Yeah.
So I could be asymptomatic, I could be working with a patient, and yet I'm quite virulent in the sense I could transmit something. So there is a certain element of risk that the patient takes. ESHRE and HFEA are also very clear that all your patients should be given an option to defer treatment if they do not want to have IVF during the pandemic. So we're not saying that you have to come to treatment now. The first thing that we have to responsibly make our patients aware that they have a choice to defer treatment for 6 months if they want to.
Okay. Another question that's coming up, and since we're talking about testing, do you test the husband as well? And would like frozen semen be a better option for them? So if you get them tested once, freeze the sample, and then just use it later on, and not let the husband come back to the lab for the rest of the cycle. Is that an option that you guys are considering, or are you taking fresh samples? Or yeah, your thoughts on that?
That's a very good question. The HFEA hasn't put any kind of restriction on IVF labs to consider freezing of samples, but I think it's a very good question. The first question was, are we testing the men as well? The answer is yes. We are testing the couple together at the
Okay.
same time at the predetermined time during stimulation, so that we're essentially covering both
Okay.
views of it during stimulation and potentially after. As you know,
Okay.
Keshav, you could be testing every day on a patient. You could have a single
That's
patient and
true.
you could be testing them every day, and you would still not have covered all your bases. But somewhere we need to kind of obviously draw the line. The question about freezing the samples, one thing we're proposing to do, we haven't really taken that approach that we will only use frozen samples. What we're encouraging our patients to do is to do the semen sample at home and to have a non-contact approach of delivering the sample to us. As they call it in the US, the curbside, the roadside sample assessment. So we will get all of our patients to do their
Yeah.
sample at home, bring it with them, and then the lab will process it from then on. Also trying to minimize the use of the same room between patients. And of course, you could have decontamination and everything going on. But that still puts your staff at risk. It puts the multiple patients who are going to be entering that room to do a sample as well. So we've taken an approach,
That's
samples have to be done at home.
okay, so that's good. But again, I'm not sure how well this approach will like happen in India, because we're really worried about the identity of the sample in our scenario, and there are issues with that. So maybe with proper consents, we can also think of it and then just decontaminate the container properly and then use the sample, or something like that could be offered in India as well once we begin. Uh,
Or
Otherwise,
as you said, Keshav, freezing the sample is not a bad option. I think that's a good
it's
option.
not as bad as an option. It's
Yeah.
just one extra step. It's not expensive, so that's also something that can be thought for patients here. Now, let's move on to a little bit of about the lab and the precautions that we're supposed to take in the laboratory, because we've already it's already 33 minutes that we've been talking about, and we have all about 25 minutes left. So let's be a little quick. Precautions in the laboratory, Alpesh, with the equipment first, and then with the staff.
Okay. So let's take it reverse. So first, let's talk about staff. Staff will definitely need to have the right PPE. You also touched very briefly earlier on having mini teams, because in a busy clinic that does 15, 16 egg collection, one of the recommendations made by ESHRE and HFEA is consider having shift work, whereby you do
Yeah.
half of egg collections in the morning, half of your egg collections late afternoon, just so you're minimizing the risk for staff and patient flow. So that is something definitely worth thinking about. That if you run a very busy clinic, you want to make sure that you may want to have mini teams. So
Yeah.
3 embryologists in the morning or 4 embryologists in the morning, four in the afternoon, etc., etc.
Right. A minimum of at least two people. A
Yeah,
minimum of at least two people in the laboratory at like any given time, because we
of
want
course.
to witness everything, and all of those things also have to be taken care of, right?
Correct. So
Yeah.
in terms of the PPE, let's talk about the PPE a bit. Masks, FFP2 masks, they're very specifically prescribed FF2 masks that we are expected to wear. Gowns on top of our scrubs,
Okay.
visors. potentially, of course, not for when doing procedures when we're looking down the microscope, but procedures which are more patient fronted. So we're expected to potentially anything where we're exposing ourselves with a patient, we're expected to cover ourselves with a visor. Of course, the tricky part will come with something like an embryo transfer, whereby you're loading the catheter and going in the room whereby the patient is exposed. So that is something that really needs to be thought through. And of
Yeah,
course, gloves, but changing the gloves after each application, not just one application, after each application that you do. So
absolutely.
that's very important. So that's PPE. In terms of the lab, we've talked
Can
about
I
the
can I break you for 1 second? So there is this concept, and I've heard a lot of people talk about this, where they say that the embryology lab is probably the safest in this current situation, and thus we can actually utilize the major PPE in the other areas where patient movement is much more, and the embryology lab maybe just a mask and gloves should suffice. You agree with that? I really don't, but
No, I don't
you're
agree with that. I think we need to have the basic level of PPE available. Don't forget,
yeah,
in the UK, we're also worried about, a indemnity perspective. So if your professional guidelines tell you to do something, and if we do not follow them, then we are potentially risking our own indemnity insurance if something, if there was a lawsuit or anything like that. So it is important that staff are given the correct PPE that the professional bodies recommend. So that is the PPE side of things. We've talked about sterilization, we've talked about validation of equipment. Now you ask me what other specific precautions that one takes in the lab. So let me touch a bit about that. For example, egg collections and sperm prep. So one thing that the HFEA, or sorry, the HFEA have said that anything where there is native fluids, native body fluids, such as follicular fluid and semen, should be diluted down. So again,
okay.
when we are essentially, once we've finished using a semen sample from the pot, you don't just discard it straight in the bag. You add water to it, dilute it to reduce the bioburden, close the cap very tightly, and put it in a clinical waste bag. The second thing is about waste disposal. All the bags are supposed to be double bagged. In a normal scenario, we would just have one bag. But in this scenario, we're double bagging all the waste that is coming out. Thirdly, how to minimize taking the dishes in and out. For clinics that have got the added advantage of having time lapse, it is important that you really try and utilize your time lapse systems right now to prevent the dish coming in and
Yeah.
out, the operator handling in and out, multiple operators handling the same sample, etc. etc. One thing that we know, which is good news, Keshav, is that there is no receptors on the egg, sperm, and embryos for COVID. So it's
Okay.
not. That's certainly that's what's emerging, that there is no receptors. So we can't
There was a
infect
lot of talk
the embryo.
on, there was a lot of talk on the ACE receptors and ACE2 receptors, which were there on the embryos, and there is the same kind of receptor that the COVID virus uses. So all that is because I know a
It's
lot of
very
people from India are also doing
hypothetical.
research in this.
Because we
Okay.
were speaking. I was part of an American webinar last week, and the consensus in that was that essentially embryos do not have the receptors, positive receptors for COVID. So what was essentially debated in that approach is that that doesn't mean that we become lax in the lab,
That's
because
true. That's true.
the culture media can still have the virus. The virus will
Yeah.
not stick to the embryo, but the culture media can still have the virus that you potentially infected with. And if you're going to cryopreserve the embryo, you still have that virus being cryopreserved. So you can still easily infect a woman because the culture media may have the virus, although one can
Yeah.
argue that what is the bioburden of this virus and is it enough to infect?
That's true.
But
And,
theoretically,
and what I heard, and you were I'm sorry. What I heard, and you were also talking about the same, is dilution is the key here. And when you dilute the media, or if you're using larger volumes in such a scenario, you're reducing the bioburden, and you're actually minimizing the risk of actually having cross transmission. So that's another strategy which I think clinics can now think
definitely
of.
diluting the native fluids, not diluting the culture media. So we need to make
Okay.
sure that the follicular fluid that has been examined, when it's being, so obviously when we do egg collections, we collect all the follicular fluid in a pot. But when we discard that, it needs to be diluted down and then discarded.
I agreed. I agree with you on that point. But now, if you're culturing embryos in like small droplets, or do you culture embryos in a larger volume now, in order to counter the same kind of phenomena? This was again something which was being discussed 2 days ago as a strategy.
Again, you see, if you're going to be using time lapse, then you don't have that
You
added
can't really do that.
you can't do that. I feel
Yeah,
that uh, the benefits of using time lapse in this current scenario outweigh the hypothetical risks of whether a 50 microliter is too small and a 250 microliters is enough in terms of
that's
the
true.
size. So I think I
Yeah.
would rather have my staff avoid touching the dish in and out every day. So it's good. It goes in at ICSI and it only comes out at embryo transfer or cryopreservation.
Maybe we just assign one staff per patient. So all the dishes that are being touched, only one staff does that for all particular patients, so that actually we're trying to control on the transmission again between dishes.
Of
Would
course,
you be thinking of on those lines as well?
yes, I
Okay,
think,
let's talk about.
yeah. Sorry, yeah.
Yeah,
About plasticware, I just want to add that the extra steps that we're taking is we're also making sure that we're not leaving open batches of plasticware. Traditionally, what we would have done if we open a pack of dishes, if we use half of them one day, you would tape it up and use half of them the other day. But now we're taking this added approach that everything gets disposed of at on the same day. So that is very, very important.
okay. There are a lot of concerns regarding media and media availability as well. Um, what's your take on how to receive media? Any special precautions that you're taking now when you receive batches of media, like decontamination, like all of those protocols?
So when we receive media, what we do is we first, we take them out of our whole ice packs and everything. We bring them into the lab, and we obviously we don't handle any bottles of media with bare hands. We never used to do that before anyway. We were always wearing gloves when we handle the media. But again, this time you may want to make sure that you put on a fresh pair of gloves, and then we wipe all the bottles with each safe wipes. We get each safe wipes here, so we just wipe all the bottles and then stock them in the fridge. We wear masks. But apart from that, there's nothing else I know of that we can
Yeah,
do additional. And of course,
just basic.
you don't open the bottles in room conditions. You have to open them in laminar class 2 cabinets. But again, this is one thing that
True.
I don't know how prevalent class 2 cabinets are in a lot of the labs in India, because I've heard that there's a lot of class 1 cabinets, not necessarily class 2 cabinets where there's a shield in the front which protects the operator. So also to bear in mind that if you're working in a class 1 cabinet, this is not necessarily protecting the operator. So when you're working with these native fluids like semen and follicular fluid, you are essentially exposing yourself as well.
Yeah. So these are things that we have to now really watch out for, especially in our scenario. Now let's move on to our protocols. Now, will closed systems be like mandatory for such patients now, or we can still think of open systems with like separate cryocans? You were talking about closed systems like a few minutes ago.
We were having this debate yesterday between the WhatsApp chat of all the lab managers in the UK. And there's been variable approaches that have been taken by several labs. In my lab, what we're going to be doing, anyone who becomes symptomatic or tests COVID positive, if they are a cancer patient, etc., then they would go in a closed system.
Okay.
Okay. There are some clinics who are continuing to use an open system throughout because they believe that the risk of cross contamination is absolutely non-existent. So that is what some of the clinics are also doing. What some clinics are also doing, they're buying a separate viewer to accommodate all the patients who are symptomatic or COVID positive as well. So
Yeah.
depends which approach we want to take. In my opinion, I would just use, if you're comfortable using a closed system, I'm not saying universally change your vitrification protocol because you need to validate it, of course, but
Yeah.
we are going to be using rapid eyes in our lab because I'm quite comfortable with the rapid eye system only for the patients who are symptomatic or COVID positive.
Yeah, perfect. And even if you're not using like a closed system, probably having like a separate dedicated crowd tank for uh, maybe such patients, especially for fertility preservation patients. I'm sure we're going to triage them, and especially for the next 3 or 4 months at least, and then only we start dealing with such cases. But even for the asymptomatic ones, if we are dedicating a tank for them, um, I don't know. It might increase on the
It's
cost,
so
but
far-fetched that we may have a second wave, and then what? So you have another time. We don't know if there's going to be mutations of this virus, etc.,
it's
etc.
so difficult. It's so difficult to predict how the situation is going to be in the next few months. And like you said, a second wave is something which can happen. So we have to be prepared for it. Okay, so social distancing is something that we didn't touch upon for the lab staff.
Hmm.
Uh, your
Yeah,
take on it? You're just
sure.
two people, but
We're just
for a for a
so I
lab which has
tell you,
more.
there is detail to the degree that in the lab you should not be sharing pens as well.
Yeah, so that's the thing that we don't even consider.
Yeah.
So what are your SOPs for social distancing?
Okay. So our SOPs for social distancing, as far as lab staff are concerned, is, let's hypothetically assume that we are a big clinic and we have 15 embryologists. So I would certainly take this on board, whereby you work in mini teams. As far as your social distancing measures go, you try and avoid paper being generated. So if you have an electronic patient management system or an EMR, try and do a live data entry on everything, and of course try and decontaminate the keyboard after every use. But we know that paper can harbor the virus as well. So we want to make sure that we really don't try and generate paper which is being handed around from one person
Yeah,
to the other. All these little things, I know they sound silly, but I think essentially if you're really going to try and troubleshoot a system, you really need to look at the whole system. Of course, there has to be an effective 6-step hand washing system protocol in the lab. I know we as
okay.
embryologists are very pedantic about hand washing, but ask yourself, how many of us really use the 6-step hand washing technique? And the answer is very, very few. So
Yeah,
the frequency of hand washing has to go up, again, potentially after every procedure that we do, and it has to be in the effective six step. We are using chlorhexidine as a soap to kind of
okay.
wash our hands. But again, chlorhexidine is effective against the virus, so we're going to be using it. And of course, I think among staff, you want to make sure that even when you're witnessing, I appreciate you need to be in such close proximity with the person who you're witnessing. Now, if you have an electronic witnessing system, then you're quite blessed. We don't have an electronic witnessing system. So again, we have to risk assess that whole
Yeah.
witnessing, that we're not bringing someone so close to our faces to watch a dish, and yet that could be a source of infectivity.
And
So yeah.
even with the electronic witnessing system, because like I'm using an electronic witnessing system, I think one thing that we have to make sure is that only one person is handling all of those tags, all of those dishes, etc., etc. So that's also something, like we mentioned earlier, assign just one person to handle the consumables related to one patient, and try and segregate that throughout the schedule that you're trying to develop for your laboratory, which would be one effective way of actually minimizing the risk of transmission from one person to the other.
Absolutely. So, yes, there are some steps which are going to be very difficult to perform at social distancing, but I think we can certainly identify many areas whereby we don't need to. So, I give you another example. So, when we
Yeah,
prepare semen, of course, we
yeah,
try and prepare one sample at a time, which is usually the practice in many labs. But usually, what you
that's
would
true.
have is you would have an embryologist watch you at every stage, i.e., when you put the tube into the centrifuge, take it out, do the density gradient. What we have started doing is what we're going to be doing is we're going to do the whole sperm prep, not bring the next sample in, and then the witness goes in and checks the pot, the first tube, the second tube, and the final tube of suspension. So everything can be witnessed at once rather
One
than
point.
all together.
That's a cool idea, Alpesh. Just going back to the procedures, I'll touch upon. Let's touch upon what to offer these patients. Do you think that IUIs and IVF are better as compared to ICSI, or do you think ICSI should be done for such patients now? Before we move on to the other precautions.
I mean, we haven't in the UK. We have not said that we're doing ICSI for all the patients in this COVID pandemic.
Yeah.
I think it rests to be argued whether IVF is more
Because
prone to infecting because of the bioburden, etc. So we are
because
still
when we talk about like viruses like HIV, in such scenarios also, if you're like doing a viral decontamination by preparing the sample properly, IUI is probably the first line of treatment for such patients. So would that be the same kind of principles that we work upon for COVID? Because
well.
I know there's nothing of these sorts out yet.
We don't know whether the sperm washing protocol for HIV is the same in effectivity for COVID.
Yeah, that's true. We
We
have no
don't
clue yet.
so I think there's a lot that is unknown here, whether
Yeah.
IUI is a better treatment option than IVF, or whether ICSI is a better treatment option than IVF. So I am convinced, Keshav, that before we locked down, we didn't know so much. And even at that point, we had quite a few positive patients. If you ask me, hands on my heart, do I have any COVID positive patients in that tank? The answer will be yes.
Okay. Or it would be I have no clue.
We haven't tested them. You see,
That's true.
we don't know. We don't know. Don't forget, there is a lot of patients who are asymptomatic, right?
Yeah. Because
So,
I was reading the news yesterday, Alpesh, and there's this news from coming from France, and they're actually saying that they've tracked back the first case to December.
hmm,
So it could have been there in our countries from as like from December onwards, and we have no clue.
correct.
So we really don't know. But coming back to the common questions now, Kalyani here asked, what are the precautions that you would take for semen analysis and like semen collection? We've already touched upon semen collection, but for the semen analysis part of it, uh, again, do we decontaminate the microscope, or again assign just one person to do it? Uh, what's your take on that?
So theoretically, a good lab should have a startup and a shutdown protocol in this pandemic scenario. At startup, everything gets wiped down, including your equipment, including your microscopes with USAFE. And at shutdown, you do the same. And in between procedures, you also decontaminate. It takes 5 seconds to just wipe it around. Now, PPE is important, that you wear a mask, you wear a hat, and you wear scrubs and gloves, of course, when handling any body fluids. So that is quite important when handling semen. And I think apart from having your PPE, you clean your microscope, there's nothing else you can do. And make sure we please have a mask. But we've
Yeah,
touched on how to collect semen, um, in the current scenario.
that's true. Now, let's take a few more questions, and then I think we can. We have about 6-7 minutes before we finish this. Parag here has a question. Now, this is an inevitable scenario for all of us in the coming months, where we might
Yeah.
get positive patients in our clinics. So now, should we
Mhm.
dedicate equipment for them?
The answer is yes. If I have a COVID positive patient that I know is COVID positive, you have to treat them as if they are HIV positive. So you have to essentially have dedicated equipment for them. We work with benchtop incubators here, so we would then give them an entire benchtop. I repeat, not using one quadrant of the benchtop.
The benchtop.
Essentially,
The
they
entire.
share, yes, they share the same humidification system. So you can't have that I'm giving them one half of it so I can culture the patients in the other half of it. No, they're sharing the same humidification system. Your viruses could literally hop from one side to the other through the humidification flask. So I mean the entire benchtop incubator has to be dedicated to them. And of course, you would freeze them in a closed system, as I said.
Okay.
And again, one
Uh,
thing I want to add, I know that those chambers are very popular in India, those closed environmental chambers, and I'm a fan of them. But I think in the scenario, because those do not give you the class 2 protection to the operator, you want to make sure that you're working mostly in the laminar flow cabinet, especially when you're working with native fluids where the bioburden can be quite high. Yeah.
yeah.
So
And
all the
from
other
what
procedures, embryos, you
I'm
can use the chamber, but not necessarily follicular fluid egg collection and sperm prep.
And from what I know, that these I don't have a closed system in my laboratory, but from what I know, it does provide humidified air uh, inside the chamber, right? And this could be a potential source which might contaminate all of your equipment which is inside, and the dishes and the whatever you're doing inside as well, right?
Correct, correct.
Okay.
Because
So
you
Parag,
use the humidification system, and you could have the virus staying in there overnight, and then next day it's still there.
yeah. Okay, Parag has a question to his same question. Now, if you find out that the patient is positive and you've already cultured the embryos in the incubator, do you actually like quarantine that incubator, or do you clean it, or how do you disinfect, and when can you restart using such equipment?
So essentially, if that patient has shared that incubator with other dishes, then I would treat all of those other patients as a quarantine patient. So what I mean to say, I would use um, a closed system for all of them because they're potentially
Okay,
all exposed. And then once the
that's
incubator is out of use, you totally clean it up with safe again and sanitize it with water, sterile water. Your typical protocol to clean out an incubator.
Do we have any studies on how long this virus is surviving on like incubator surfaces, etc.? Do you
So
have
on
anything for
dry
that?
surfaces, they're saying it's 72 hours, if not more.
Okay. So if you're like if we have to take the maximum precautions, not use that, so we don't use it for at least 3 or 4 days.
Yeah,
But disinfection, cleaning the incubator again with USAFE,
yeah.
these are general things that we can easily do in the
Yeah, I
laboratories.
wouldn't advocate that you don't use an incubator for 4 or 5 days because you may need to use it. So the easiest thing to do is just use USAFE, disinfect it, clean it out, throw the humidification flask out, and put a brand new flask and start from scratch.
Yeah. I think this is another good question here by Syed here. And he's talking about vapor storage tanks for such patients. Uh, I don't think any of us have access to vapor storage tanks in India. I'm not sure if anyone's using it. But what about your experience with them? Have you used vapor storage? It's Is it safe? Is it effective against decontamination?
So no, I
Or
haven't used vapor storage, and I would never have the courage to use a vapor storage tank. I just feel that it's quite risky, in my opinion. I've always used wet storage systems, just because of the added advantage of time if something goes wrong. But in the current scenario, one of the things that Eshre has mentioned is consider freezing in a vapor storage system because there is no direct liquid nitrogen contact. However, as you know, Keshav, all these risks are theoretical.
that's true. And the best that we can do in such situations is to take the maximum precautions that we can in order to offer the best kind of services to our patients. So Alpesh, last 2 minutes, can you just sum up the key points and the way that we all should go ahead for our clinics, and then we can end this.
Sure. So in a lab, I can say that the three things I'd like to say is use the correct PPE. That is very important. Try and minimize your exposure to native fluids, and especially when you're doing egg collections and sperm preps. Um, Save your samples in terms of the vitrification side of things. Consider using a closed system, and make sure that your aseptic techniques and your disinfection protocols are very, very thorough and robust, especially in this current climate. Trust me, I know it's horrible to be cleaning day in, day out, every time, but it really needs to be done.
Yeah. We'll take this question because this also seems relevant. Should we increase the frequency of contraconing the incubator and like decontamination cycles for the incubator in this period, or is regular disinfection good enough?
So you see, generally nowadays we don't recommend culturing embryos in big box incubators, and the Contracon is more of a big box incubator setup. So if you are using the big box incubator to culture your embryos, then yes, please do increase the frequency of your Contracon, because everything that you can do in addition is an added advantage.
Yeah, that's true. And I think, again, taking maximum precautions without compromising on the health of the laboratory is something that we have to consider. Contracon does damage the sensors a bit. So
Yes.
increasing the frequency of that, so you have to be worried about your sensors. You have to take the gas readings properly, maintain all your QC in place, and these are things that we have to consider. Last thing that I want, Alpesh, you to touch upon is the documentation process in the laboratory now, and again, maybe a little bit more on consents and how important it is now to counsel our patients effectively in these like how do you counsel your patients, or how do you intend to counsel your patients once you begin the clinic
So I think
regarding the risk of transmission?
yeah. So one thing which is very important is that patients are aware that their cycle could be cancelled. So that is
Okay.
the biggest risk that patients need to be aware about. That if they want to start treatment in the current climate where all these social distancing measures and everything are in place, that may add to their delays in terms of waiting times, etc., etc. But biggest risk is that their cycle could be cancelled. Now, with a patient who is losing her time because of AMH and all that, she has no option but to go through it. Now, what was your other question, Keshav? You said something else. Sorry. Consent.
uh,
So there is a
Consents.
consent. Yes, there is a consent in place which would cover that your treatment cycle could be cancelled. We're calling a document a code of conduct in the UK,
Yeah.
which is going to be signed by staff and patients, which is going to be saying that they are going to be minimizing the exposure of them to the outside world, because ultimately we have a clinical responsibility to the patient, and the patient has to us as well. So there's going to be a code of conduct as well we're going to be filling in. Apart from that, other documentation in the lab and everything is pretty much standard. Of course, I do encourage lab managers to keep a very good control on the dates and the times. Everything is sanitized, disinfected. Show your, in the UK, when we have an inspection, they ask to see all the cleaning records. And I'm sure that the next inspection we're going to be having, they are going to be wanting to see how often we have cleaned everything. So please make sure that your cleaning logs and everything are absolutely 100%. They're filled in with the correct information, and most importantly, that you're showing that you're doing more regular cleaning and disinfecting.
And this is something which we all have to take as a responsibility on ourselves, because we don't have like guiding authorities in the country. We don't have regulatory bodies which control the IVF scenario, and therefore it becomes our responsibility to actually ensure that we are offering the best kind of practices. So maybe have regular audits, maybe do this like have your clinic director check upon all of these things, and try and maintain logs for cleaning. Again, if there's a scenario which happens where a patient comes out positive, you might have to track back who all came on that day. You might have to do the what do you call it, where you actually look for people who came into contact with that person. So
Yeah.
all of these things you might be responsible for, and if you have a good documentation process in place, it'll be very easy for you to actually minimize the risk of transmission.
Can I just
In
add one more thing?
Yeah,
Keshav, we touched on this before we went live, is that next week we get the SAQ in the UK
yeah,
from our regulators. So what I'm quite happy to do is forward the SAQ to you, and you can potentially send it further on to the professional bodies who can circulate this to individual clinics if they want to use the template of the HFEA SAQ. From what I
I
have
would love
seen
that.
so far, it's a fantastic, very thorough self-assessment questionnaire that will 110% get the clinics ready to treat the patients during the pandemic.
Awesome. Thank you so much, Alpesh. And I would really be happy to share that across the platform here, as well as to our governing bodies. And thank you for your support. As always, you've been such a great friend to all of us. And more power to you, because you're
Thank
the
you.
one who's going to be beginning the IVF scene very, very soon. So we are going to be looking up to you for guidance for our laboratories, and looking up to you with the challenges that you face in the coming times, so that we can actually take care of those as well. So thank you so much for joining us today,
Pleasure.
and
Thank you.
hope to do more sessions with you very soon. We've had a great audience today. I can see that almost 120 people are still live with us.
Wow. Thank
So
you.
this was a fantastic session for the both of us, and for all of the people and the comments that we are getting. So hopefully we can do this again.
Thank you. Thank you, Keshav. You take care. Stay safe, huh?
Thank you so much,
Thank
and bye
you.
bye.
Thank you. Take